I want to continue with the next live voting question, which is how do you treat patients with ACL failure and a posterior tibial slope of 13 degrees? Do you do ACL revision surgery only or in combination with anterolateral tenodesis, in combination with slope-reducing osteotomy, or slope-reducing osteotomy and anterolateral tenodesis, or slope-reducing osteotomy only? If patients suffer from persistent instability, then ACL revision surgery will be performed at a later time point. And while you at home have the possibility to answer these questions, I want to introduce the next talk, which comes from Elmar Herbst, and he will talk about the importance of the slope in ACL instability.
Ladies and gentlemen, I'm talking about slope in ACL instability. I have nothing to disclose. When looking at the ACL failure rates, we have to face an extraordinary high failure rate, especially in young patients less than 25 or 20 years of age, with failure rates ranging between 10 and almost 30% at 3 to 5 years. And also the contralateral ACL injury rate is fairly high in this specific population. When looking at reasons for ACL failure, we all know this graphic from the Moon cohort describing the traumatic, technical, and biological issues in ACL failure. However, this is kind of old school. When looking at this systematic review from Thomas Tischer, he described extensively the role of bony alignment in ligament surgery, and they found that a steep posterior tibial slope above 12 degrees is a major risk factor for ACL failure. When having a closer look at a steep posterior tibial slope, it has been shown that it's associated with a high-grade pivot shift even following ACL reconstruction, a higher degree of internal tibial rotation during running and walking, and especially a high difference between the medial and lateral posterior tibial slope is more prone to internal tibial rotation and therefore high-grade anterolateral rotatory knee instability. Biomechanically, it has been shown that a steep posterior tibial slope above 12 degrees is associated with an anteriorly directed force vector and especially an increased ACL graft force. And when looking at the graphs below, you can see the almost linear relationship between the posterior tibial slope and the graft force on the ACL. When having a steep posterior tibial slope, this could reduce the graft force within the PCL. Now the question is, can we reduce the ACL graft force by a slope-reducing osteotomy? And this study from Imhoff has shown on the left side with 200 newtons axial compression, on the right side with 400 newtons, that a slope-reducing osteotomy is efficient in reducing the ACL graft force. The question now is, should we also address varus malalignment, as varus malalignment is associated with a higher force within the ACL graft and therefore a risk factor for ACL failure? And again, Imhoff has extensively investigated this issue, and they looked at combined slope-reducing osteotomy and varus correction. And if you look at their data, they found that anterior tibial translation was efficiently reduced via slope-reducing osteotomy, while a concomitant reduction of varus was not as significant. When, however, looking at the ACL graft force, a combined slope-reducing osteotomy and valgization was efficient in reducing the ACL graft force. The question is, what should we do clinically now? And this is a landmark study and the most important study, I guess, on this topic. It's a 20 years follow-up outcome study on 200 primary ACL reconstructions. And the authors described a graft survival rate at 20 years of only 22% in adolescents if the slope was greater than 12 degrees. And when looking at the combined survival rate in adults and younger subjects, patients with a slope above 12 degrees have a 20-year survival rate of not more than 69% with regards to their ACL grafts. So it seems that the major cut-off point for a clinically relevant posterior tibial slope is 12 degrees. This is one study evaluating the clinical effect of a slope-reducing osteotomy in ACL revision surgery on 20 patients, and they found that after a slope-reducing osteotomy and combined anterolateral tenodesis, the side-to-side difference, as measured using the rollimeter, was almost zero. Furthermore, the authors described a slope reduction from 15 degrees to about 9 degrees post-operatively. And interestingly, and this should be noted, patients have more extension or hyperextension following a slope-reducing osteotomy. And this should be considered when opting for a slope-reducing osteotomy. Our clinical question nowadays is how to measure the posterior tibial slope, as several studies have shown a high variability among different imaging modalities. Most commonly, and this is how we do it, the lateral radiographs of the entire tibia are used. Short radiographs can be used, but measurement accuracy is a little bit lower. MRI and CT scans are helpful, however, to properly plan the osteotomy, radiographs should be performed. This is one option to perform a slope-reducing osteotomy. After proper planning, we do a infratuberosity slope-reducing osteotomy. By doing so, we can also correct a mild or some degrees of varus and valgus malalignment. And we usually use angle-stable locking plates as shown in this image here. So let me conclude. The posterior tibial slope is an important predictor for failure and persistent anterolateral rotatory knee instability following ACL reconstruction. And 12 degrees seem to be the most important or relevant cut-off value as measured on lateral radiographs. When diagnosing a posterior tibial slope, we can use MRI and CT scans as well. However, lateral radiographs are the standard of care. Biomechanically, slope-reducing osteotomies are efficient to reduce ACL graft force and normalize knee kinematics. And we can also treat patients with mild varus and valgus malalignment. However, clinical data are pending. Thank you very much.
Yeah, thank you, Elmar, for this presentation. Clear votum for going for slope reduction osteotomy in cases of ACL deficiency and increased tibial slope. I'm wondering how our audience voted in our question we had, and we were asking in a patient with an increased slope of 13 degrees, and the majority goes for an ACL revision surgery and slope reduction osteotomy. We can discuss if this is going to be a single stage or a two-stage procedure. Maybe it also depends on the status of the drilling channels for the ACL. But if you asked this question probably 5 years ago, the amount of viewers that are decided to go for an osteotomy would probably really less. So coming back to Elmar, so you have probably performed quite a large number of these osteotomies. What is your personal feeling in terms of doing this surgery? So do you feel comfortable with the surgical technique? Independence from the scientific evidence available. Just maybe you give us a short comment on your personal experience in doing these slope reduction osteotomies. What do you consider most important in terms of patient selection?
Well, actually, I think right now it's kind of en vogue looking at the slope. So for years we haven't looked at it at all. Now we look at it very aggressively, and so we had diagnosed many revision cases with a steep posterior tibial slope. Therefore, we are very straightforward with the indication of slope-reducing osteotomies, and actually we are doing quite a bit of these, and we start correcting some degrees of varus and valgus, which is, however, challenging. When doing when using this technique, we do it with the starting point distal to the tuberosity. I feel really comfortable doing that. When going above or below or behind the tuberosity, it's a little bit more challenging. But starting inferior to the tuberosity is okay. However, when doing the cut posteriorly, you have to make sure that the cuts are clean, that you can close the osteotomy properly. This is always a little bit of a challenge if you start doing these osteotomies, because you're too afraid to go far enough posteriorly. I'm pretty sure, and this is why I asked the question with the 13 degrees, I'm pretty sure that maybe nowadays we are a little bit too aggressive. Future will show the clear indications when to do the slope-reducing osteotomy. One key factor for me, at least, is if the patients can first extend the knee fully or not, and if they have hyperextension. If the patients present with already 10 degrees hyperextension, and we do a further slope reduction of 5 or more degrees, we will end up with a potential catastrophic knee case with subjective instability in basically all directions, because the patient will have a hyperextension of even more than 10 degrees. So we need to be very careful in these hyperlex patients.